How's it going, everyone? Welcome back to the Rehab Science Podcast. Super excited about today's episode. I have clinician and educator Greg Lehman. Greg's a physiotherapist, a chiropractor. He has a master's degree in spine biomechanics, worked for a long time as a researcher and educator. Greg has actually been extremely influential in my own development. Back in the day when I thought all pain was posture, structure, biomechanics, I got involved in some Facebook pain science groups, and for probably 5 years, Greg was one of the people that really helped me understand more about pain science and how it just helped me kind of think differently about how I would treat patients and just getting away from such a tissue-driven model, the model that I really learned in physio school. So, Greg, so excited to have you on the podcast. Thanks for coming on.
Yeah, thanks for having me. It's good to be
Heck
here.
yeah. So I've got a few questions for you. I want to start off. You label yourself or refer to yourself as a movement optimist. What
Yeah,
does this mean to you?
that's me, the original. Well, I just came up with the term, but
I like it.
there's been plenty of movement optimists through the decades. I actually think rehab in the past probably satisfied this,
Uh-huh.
which was at its simplest. This is movement optimism, which is treatment for any ache and pain. Is we just calm stuff down in some way. Usually back off, take it easy, take care of yourself, and then build yourself back up. Right? What do you have trouble doing? Okay, well, let's start doing that. Uh, it could be the goal tasks like gardening or walking or hiking, or it could be with exercises and things like that. But somewhere along the way, like we fell into this model of like really needing to fix people with very specific interventions. And it was all predicated on a really negative view of human function. Like your SI joint is shifted 2 millimeters and you can't control this muscle and your muscles aren't turning on in the right order. And so like, I just found it was such a pessimistic view of human function and resiliency that this movement optimism was needed for people.
Yeah, I love it. It again, this is another concept and I think a line of thinking that I really learned about from you, and it has shifted a lot of how I think. I think this idea of just keeping things more simple with patients. Like we're going to calm things down and then we're going to gradually build things back up. And I can't tell you how many times I've said that to patients, and it stems back to hearing you kind of
Yeah.
start talking about this. And I think because I came from a very specific my education was very specific in terms of let's find the pain generator, something
Yeah.
specific in the person's body, and then give them a really specific intervention. And, sometimes people would get better, but sometimes people didn't. And I think sometimes that type of education made people worry about little things in their body, about could I turn on a certain muscle, or was I not turning it on correctly? Or, like you said, is my SI joint out of alignment, a few
Yeah.
millimeters or something? And people would latch on to these little fine details about their body and then worry about them. And so I have become much more simple. I've been a physio now for 17 years. It seems crazy that the time's gone by this fast, but I'm so much more simple in the way that I approach things now. And like you, I had an exercise science background, kinesiology background. That's where I
Yeah.
came from. And so kind of in some ways feel like I'm going back
Yeah.
to just my regular exercise background. And it seems like you kind of, I know you have your strength and conditioning background, and I see a lot of the topics you talk about. It seems that way. Maybe I'm wrong, but for you as well, that getting back to just exercise basics.
Oh, yeah, for sure. Just exercise and activity and meeting people where they are. And like so when I'm critical of that fix it mentality, I'm not saying it's not helpful.
Mm.
Like when I look at what's traditionally taught, which would be like we're going to fix your faulty movement pattern. We're going to fix the muscles. We're going to get your glutes to fire. If I just watch those people practice and turn the sound off, and I didn't hear what they said, I'd be like, this actually looks okay. It's satisfying the criteria of calming it down and building it up. They usually teach someone to avoid something that's aggravating, and then they add exercises that build them up to do that thing. Like it's really simple.
Yep. Yep.
And so
It's
I'm never denigrating people's like clinical success. I'm just saying, look at really what you're doing and ask, can I explain this another simpler way? And could I achieve it a bunch of other ways as well? Like what
Hmm.
are the options here?
Yeah, it's so true. It's like you say, if you turned the audio off and didn't listen to the education, it would look, most people would look great. Like they're probably
Yeah,
getting good results with that. It really is kind of the clinician messaging, and
yeah.
how that affects the patient. When you think about education, educating patients, besides this idea of maybe kind of keeping it simple, like we're going to calm
Hmm.
things down. We're going to look at kind of graded activity, whether that's just, like you say, gardening, it could just be gardening,
Yeah.
housework, it could be exercises. When you think about educating patients, when it comes to pain, that seems like there's been kind of some rethinking about how much we go into the education of pain science type material. Where do you stand on that now?
So I no, I've always been consistent. I have a old slide from my course 10 years ago that said we don't have to be neuroscientists
Mm,
to help people understand pain.
yeah.
I've always thought you had people like David Butler and Lorimer Moseley, and there's a subset of people, they're too smart for our profession. And I feel like they need to do they need to understand the complexity for them, but our patients don't need to know that.
Mhm.
They need to know basics. That's why in my book, like the recovery strategies, like the online thing, it's just I just simple key messages. What's the simple message that someone needs to know that will resonate with them?
Mhm.
Like you can adapt.
Yeah. Yeah.
Pain is more than just damage. It's more about
Mhm.
that's it. I've always, maybe I'm just not smart enough to like go into the complexity. I don't know shit about neurotransmitters and all the cytokines, and I don't want to, and I don't want to talk about the homunculus. Uh, you know what I mean? Like,
Oh, for
and
sure.
so I
Yeah.
just think people don't need it. They just
Mm-mm.
need messages that resonate, and that a good message that helps them understand what's going on. And then ideally, that is like the not the framework, but like the springboard for their mechanical interventions, for their other interventions that they're going to do. Like the explanation makes sense, and it leads right into the treatment, so to speak.
Yeah, I agree. I think this is why you've done such a good job. I think this is why you resonate with so many clinicians. Your ability to take what some of those really pure academic individuals are doing and translating it, because you do walk an interesting line of having that background as a researcher and educator. I know teaching at the university level, but then also being someone who's actually seeing patients. And I
Yeah.
think some of those people aren't so much in those roles. But I agree with you. I think when you get into because there was a period of time when I was really getting into pain science where I spent too much time, I swung the other direction
Oh yeah.
and told patients too much about pain.
Yeah.
And,
Yeah.
you see them glaze over and they're like, how does this even relate to what's
Yeah.
going on here? And I've definitely come around more to some of the things you were talking about of just keeping it simple, like pain doesn't always mean damage. And, just kind of the basics again of like, look, we're going to implement some things to try and calm your system down, desensitize the system, and then
Yeah.
gradually, expose it to threatening things and build back up. But yeah, I love that. One of your courses that I always thought was so interesting, I know you've been teaching for a number of years, is the reconciling biomechanics with pain science.
Yeah.
What was the motivation? I mean, I have some idea of the motivation behind starting that course, but why did you design that course? What was the
Uh,
motivation?
so I'd been in like the biomechanics field for decades, and I always thought biomechanics were important, just not the things that everyone focused on. So, like my master's, we were debunking myths of manual therapy and exercise from the get go with the people that did their PhD when I did my master's, uh, and so I would be asked to give small lectures on that for years, and then people would say, "Well, okay, Greg, if you're all doing all this debunking, tell us what to do." And I was
Mhm.
like, okay. And so that hence the course.
Yeah.
And then it was all like, it wasn't on purpose. Like, I guess I got popular online with my blog, and
Hmm.
social media was never like planned. And I was like, oh, okay, I'll create a course with just
Yeah.
selling the simple and trying to find fun. It was originally called Physio Fundamentals.
Mm.
And then and I was like, yeah, let's sell simple. And then as soon as I said yes to one invite, I was busy after that. Like it was really neat. And
How
so,
many courses do you teach a year?
so I used to teach more, but I've probably taught over 250 in the past 9
Wow.
years, I'd say.
Wow.
So yeah,
Stay busy.
thousands of people. So maybe I was just in Prague last week in Oslo. So
I saw you got stuck. Your flight got
yeah,
canceled or something.
it happens. I got rebooked. I almost didn't make it home. It was
Yeah.
great. Uh, so I'm a little jet lagged right now.
Hmm.
But yeah, so two a month, maybe 20 a year. I think the online is taking over more. People
Oh
appreciate
yeah.
that.
Yeah.
Yeah.
Yeah. Sometimes the travel is hard. I would imagine that, I know we both have kids and I used to love it before I had kids. And now sometimes the travel, I just want to be back home. I don't know if,
Oh, I'm a fly in, fly out. Fly in
yeah.
Friday, leave Sunday night.
Oh yeah. You're quick. Okay.
I
Yep.
did that. I went to New Zealand once. You have to fly in Wednesday. You
Yeah.
get there Friday, and then you leave Sunday night, and you get home Sunday night.
Yeah.
Like my travel time was longer than the time I was in New Zealand because I feel guilty.
Yeah.
Yeah,
Yeah. Yeah.
gotta get home.
Yeah. Well, that's great that makes sense on the course development, which is also really cool because sometimes the people who only debunk and kind of criticize other people's work, you do get tired of after a while. You're like, well, what do you do?
Yeah,
And so that's cool. I didn't know that that was how that course started. I
yeah.
thought you maybe were just looking at a need and created it, but that's cool.
No, I mean, I didn't like what was out there, and then I felt, well, if I'm going to critique, I should provide an alternative.
Yeah.
And it's
Yeah.
interesting in 10 years, like you can see that things have changed. Like I'm
Uh-huh.
certainly not the only, I wasn't the only one saying it back then, but there's a lot more people saying the same message. And same with the
Yeah.
debunking. I love debunking. It's fun, but it's easy. I don't really do
Well, and I
much
think you
anymore.
do a good job at it. You're citing research. That's one thing I've always appreciated about the way, I know we all have our biases, but you do a pretty good job, I think, of saying, like, hey, what does the research really say about this, or what does it not say? Like, I've seen you question lots of things that I right away would have thought you were like a full supporter. And I think it's not showing that you're not a supporter, but you're just saying,
Yeah.
what do we actually have evidence for?
So that's been the evolution of my critique. I don't want to punch down. I don't want
Mm,
to just go after things like that I disagree with. I want to be
hmm
consistent in my criticism. So the past 5 or 6 years, I've really said, like, what are the things I believe in? I
hmm
have to be just as critical of those things as the other things that I don't do,
hmm
right? And then I feel, I don't know what that's called, like steel manning or stress testing your own. I'm
Yeah, like
sure there's
taking
some
on the
like,
other argument, kind of like what would the
yeah,
adversary's argument be?
yeah. So if I'm like, the debates I'll have are probably with people who are more similar to me,
Mm,
right? Like if I believe in exercise for tendinopathy, or knee OA, I'm the
mm,
first one to challenge that and say, have we really been
hmm
as like critical of this as we have of a modality for knee OA or manual therapy? And
hmm
I don't think we have. And it makes me sheepish in my
hmm
criticism. Like I'm kind of disappointed in our profession for
Yeah.
not, really challenging what we think we know. Like that just leads to dogma, and then you just perpetuate the same problem. So I
Yeah,
don't
when
know.
I see you get into those topics, it makes me realize, it makes me think I need to spend more time because it is easy just to get into repeating the same messages on different topics of these are the things that work and not actually do your homework
Yeah,
and really go back and look at the research. The NEOA one, I just recently saw you talking about, and man, I can't tell you how many times I've written about exercise as being this really superior intervention for OA. And I saw, what you wrote the other day. I'm like, wow, it just was a reminder to me again of like, spend the time to go and look at what research is actually out there and what it says. And is
yeah,
this intervention I'm saying is so superior? Is it really superior?
yeah. It's tough when you make claims of superiority,
Mm,
and more importantly, if you're, I don't like when people say, "Oh, this thing over here sucks," and then you look at how they made that decision, and they might be critiquing the research behind it, and it's valid, but they haven't done the same thing for what they love.
yeah.
So manual therapy is a perfect example with knee OA. People are like, oh, manual therapy or these modalities or these passive treatments suck for knee OA. Do this exercise. And then you're like, well, what made you say, like, I can advocate, I love advocating exercise for knee OA, but
Mm-hmm.
can I tell people not to do these other things?
Got it.
And that's a higher bar that you have to pass. And when you really look at the research, you're like, you can't say that.
Mm-hmm. Yeah.
Tendons, same thing with tendons. Like, it drives me bonkers. But for years, I'll be like, you got to load that tendon. You can't just
Mm-hmm.
rub it. Rubbing it's not going to make the tendon
Yes.
stronger.
Yeah.
Don't stretch it. That won't make the tendon stronger. And then when you look at the research where they actually compare those things, no bloody difference.
Yeah. It's like,
What?
I remember you would talk about, it's like the whole mechanotransduction thing, right? Like if we cross friction a tendon or stretch it, that's putting load on it. Is that really different than loading it with resistance training?
Well, so actually, that's one of the things where I've changed on. If you asked me
Uh-huh.
10 years ago what manual therapy was, I thought
Yeah.
it was mechanotransduction.
Uh-huh.
I actually don't think so. I don't know what it does. I think it helps with pain, and I think a lot of our problems are just pain problems. So you help with the pain, then everything else takes care of itself.
Yeah.
Especially in the tendon world, because we know that you can have tendinosis and be pain-free.
Sure.
And so when people get out of pain, their tendinosis is identical. So it's a pain issue.
Mm-hmm.
It makes sense to load up the tendon to make it stronger, but although that makes a lot of sense, it's not borne out in the research yet.
Yeah.
I say because it still might be important sometimes. You just don't know.
Totally. Yeah. Like if you had imaging done on that tendon, some of the tendinosis is going to look the same before and after.
Oh, it does.
Yeah.
Sometimes the difference is like you build up the tissue around the tendinosis, and that's been the dominant theory for 10 years. So you make the tendon stronger, which manifests as more stiffness.
Mm-hmm.
And we think that would be better. But in the few papers where they compare a loading program that would make the tendon stronger, it doesn't outperform a gentle loading program, like a medium loading, or a manual therapy program.
Yeah.
That's a Radonovich paper, but there's similar ones. Yeah.
So say somebody that comes in with tendinopathy, like say I just had someone here the other day with a medial epicondylgia, like a golfer's elbow.
Yeah.
So with that person, I ended up, because I come from a manual therapy background like you, my residency was in orthopedic manual therapy. And so I use probably less of it than I did when I was a new grad, but I still will work on people because I think it does help desensitize and kind of get people moving towards activity. And so, I ended up doing some soft tissue, and I find like massage work, as basic as it is, I think sometimes it's the most helpful thing.
Yeah.
But I just ended up doing some soft tissue work, on kind of through his forearm, on his wrist and finger flexors, up towards the tendon, just kind of gentle stuff to, who knows what the exact mechanism is, but just work on that area a little bit. And then, of course, gave some of the loading exercises, wrist curls and grip strengthening and pronation stuff. But what would, like, say you had someone like that come in, what would your approach look like these days?
So certainly in the past, I would definitely try some manual therapy and stuff like that. I see people less often now, because I think that's people expect to come to see me and just get some planning. Like that's what they're expecting. So I give a little bit of their expectations.
Because they know that about you. You mean because they know who you are?
I think. And so often it's like, well, what do you want? What do you really want to do? What are your goals here? And then often they just want to keep playing golf and tennis and know they're safe. Yeah. And I'm like, you can keep doing that. We can try to tape it, see if that makes it feel better. We can do some exercises, but like medial epicondylgia or lateral epicondylgia, they're a good case of like, they can be really recalcitrant and stick around. I'm totally open to people trying some therapy for a few weeks, but just knowing that they're safe and they can keep playing tennis or something like that, even if it hurts, that's often what people want to hear from me.
Yeah.
And so I take like a load management, like let's maybe use golf as your rehab intervention. We'll do golf related exercises. And then with something like lateral epicondylgia, like plantar fasciopathy, these like really tough ones, I'm like, it sounds weird, but sometimes like these tendon like pains, they're like it's an issue in your system and it shows up locally. And this is where yours just happen to show up. So could we do other things in your life that maybe make you healthier? It sounds odd. And so we're looking at other things that might be influencing it. It could be BMI, it could be a lack of physical activity, stress or sleep or all that stuff.
Yeah.
Right. So I'm kind of looking really holistic here, but at the same time, maybe managing expectations,
Mm-hmm.
especially if they've had that for like 6 months, that
Yeah.
these things are hard,
Yeah.
and
They're
there's,
resistant and can take a long time to get better.
yeah, and there's nothing wrong with that. Like I had
Mm-hmm.
frozen shoulder over COVID.
Oh, yeah.
I was like, all I did was I got the shot. That's like the
Cortisone.
not the it, not yeah the cortisone, not
Yeah.
the COVID shot. I did get that, but
Yeah.
that's not why I got frozen shoulder. Uh, and then I was like, okay, well I do gymnastics.
Mm.
I'm just gonna stop that for a bit or modify it,
Mm-hmm.
and I'm gonna do more skateboarding,
Yeah.
and then
Yeah.
just manage my life. That's
Exactly.
often like the goals with people sometimes.
Yeah, totally. It's like you say, that's something I've learned, I think, just being in this profession longer, just to sit and actually understand, listen to people and understand what are they hoping to get out of the session with you. Because
Yeah.
as a new physio, I used to really have my goals. You know, you had your goals
Oh,
for
for
what you
sure.
thought they needed to work on, and you just bombard people with that and not really understand why they were there.
Yeah, I
And,
still do. It's the
yeah,
hardest thing, right? To
you're
really
excited to,
listen.
you're excited I think when you, get excited about education, it's hard to not talk, and you get
Yeah.
excited to tell people about, their bodies and what might be going on. And this guy who came in just yesterday, he's exactly like you were saying. He's a tennis player. He's a tennis pro. He coaches, and so he has to do that all day in high volumes. He's hitting,
Oh,
and I think a lot of it for him was just having a little bit of guidance and reassurance. I think that's mostly what he was hoping to get out of the session. He even texted me after and said that.
yeah. So that
So,
so that would be a case where like manual therapy, just that relief for a little bit,
mm-hmm,
that's not worthless. So
sure,
this is where research is limited. The research would say, oh, if you do that manual therapy program, it's not going to make a difference a year from now.
yeah,
Okay.
mm-hmm,
And I would say, when I have a headache, right, I can take a Tylenol, I'll feel better that day. It's not
yes,
going to make a difference 2 days from now
mm-hmm,
if I took a Tylenol or not. That
yeah,
headache's going to go away in 2 days.
yep,
But it was still valuable at the time,
mm-hmm,
right? And so that's where I kind of am with manual therapy a lot. Like there's value there, and this meeting people where they're at. Like people will come to me just to talk. It's really interesting now, and
mm-hmm,
that just happened weird. But it wasn't like that before. People came to me and expected manual therapy.
mm-hmm,
I couldn't just talk to them.
mm.
I had to like that. I had
You
to
had to
meet them
work
where
on
they
it,
were.
yeah.
I couldn't take an hour and a half to convince them that I can just talk to them.
Mm-hmm. Mm-hmm.
you know so
Yeah.
like it's okay if you're out there like feeling like you're struggling. You're not hurting people by doing that stuff.
Yeah.
Yeah.
Yeah. It's so refreshing to hear you say that about manual therapy, because that was definitely one of my questions. Knowing you come from a really strong manual
Hmm.
therapy background with the 4 years in chiropractic college and then the physio training, and me having a manual therapy background, like I say, I do less of it than I used to. I'm not spending I mean, the clinic I was in initially when I first graduated, we'd spend a 30 minutes of manual therapy in every patient, and then they'd go to like a kind of like
Yeah.
an assistant and do exercise. So we didn't actually do any of the exercise. I was just a straight manual therapist all day. And I'm not like that anymore, but I do definitely think there's a place for, with some people, they may have an expectation that you're going to work on them, or they may feel sort of down about the value of the session if you don't touch them at
Yeah.
all. And I think even though it may be temporary, humans are complex. And I think, like you said, the Tylenol is a great example. If you can just get some temporary relief, that can be reassuring to people, and just it helps get them on their way, I think, to the next steps that maybe do help create the longer term changes. So,
So I was just saying, at the worst case, it's just temporary here.
mm,
When you look at the long term research, it's not really outperforming stuff. Like I love CFT, cognitive functional therapy. If I
yeah,
had to describe my practice, it's that.
okay,
And when you look at their research where they compare it against a manual therapy program, it's not trouncing it,
hmm,
right? The pain differences aren't there. You might see subtle changes in self-efficacy and disability, but not that much. People are still getting benefit
hmm,
there in the long term. So I don't know. I think I don't see an issue with doing all of those things.
yeah,
It's just acknowledging our uncertainty and then treating with a wide net.
yeah, yeah. It is so true. You get some of those people, like you're saying, that the longer I'm also in this profession, the more I feel like it's talk therapy, and
Sure.
so much less of the, some people who just, I'm sure you get this, especially being out of an insurance model now, being able to spend an hour with people. Sometimes people will say, this is the first time I've told my whole story in one sitting,
Oh wow. Yeah.
because people just don't get that. I mean, the US healthcare physios are seeing so many people per day, and the quality of care just has dropped so much, even since I left the insurance model. So, um, yeah, it's the bit you were just talking about. Oh gosh, I had another thought. Okay, well, maybe it'll come back to me. The
Okay.
functional cognitive functional therapy.
Yeah,
That's
great.
that. Can you give kind of just a brief overview of what that means?
I mean, I I've taken their course and read their stuff for over a decade. So
Is that Patrick?
Peter O'Sullivan,
Peter O'Sullivan. Yes, Peter
Peter
O'Sullivan.
O'Sullivan, Kieran O'Sullivan, not related. Um, um, Mary O'Keefe,
Yeah. Mm-hmm.
Sharton Vibe Fursum, all these great researchers. JP Canero, the past 10 years have really stepped up and done stuff with them. Great research team. It's one manifestation of the biopsychosocial model.
Got it. That's what I feel
So
like when yeah.
yeah, so I don't. It's just one way to do it. Essentially, it says that our beliefs, our thoughts, our emotions
Mm-hmm.
influence our pain levels. So we want to give more optimistic beliefs
Mm-hmm.
on the body. And advice and education is key. Very simple messages. I love it.
Yeah.
Their mechanical interventions are, I mean, they might find this too simplistic the way I explain it, but again, when you watch it, it's look how someone moves
Mm-hmm.
and really change it, right? Like change how they move to a more comfortable position. So
Yeah.
often the classic CFT patient is avoidant and fearful
Yes.
and worried about bending their spine because they think
Yes.
it's going to get damaged and their disc is going to blow out. So the education here would be your spine is strong, it's safe, you're not fragile. So you would change how they move and actually start to expose them to spinal flexion, to things that they're missing, and that they would call that a behavioral experiment. It's classic exposure intervention where the thing you're afraid of you have to start doing to
Yeah.
confront yourself and challenge your beliefs about it. So that's what they're known for. But their old research papers, they would have someone who might flex a lot and their spine hurt, and they would teach a more neutral spine.
Got it.
Yeah, but you don't really hear them talking
Yeah.
anymore about
No.
that. So I don't know. It's weird. So it's just sort of saying, like, to me, it's
Find
like,
what's comfortable. Like listen to your body. Find a
trust it.
movement that doesn't hurt as much.
Yeah, and then
Mm-hmm.
let's do more of that and get you comfortable and build up your resiliency here. Not
Yeah.
just your physical, but you can trust your back again. And then all of that leads to the functional part is what are the things you're missing in your life? And we have to start doing graded activity to that. The things that you're missing, that's rehab. So the doing is the fixing. It'd be like my catchphrase, right?
Mm-hmm.
And then what I really like is you say, well, it's all a system. So everything can influence your sensitivity of your tissues.
Mm-hmm.
So let's look at all of the other things, which is like
Sleep,
health,
nutrition.
perfect,
Yeah.
physical activity,
Mm-hmm.
right? And so it's like a really wide, broad net. And this is the thing with me. I know I'm biased here, but I had my framework before. Their papers would come out. I'm like, this is like my framework. This is great research. You know what I mean?
Mm-hmm.
Like it's not the way to choose something because it resonated, but it resonated with
Yeah.
me. And they're good people and they care and their
Mm-hmm.
research is good. So I don't know.
It seems
I
like
like them.
yeah, no, it matches up so much with what you do, and it seems like a great spot. It seems like where our profession, it feels like the right spot to me right now. Like it kind of brings in the movement optimism. Like let's focus on reassuring people and encouraging them and staying positive. And then, listening to, I think for so long, posture is a great example where people have this idea of good and bad and good posture.
Yeah.
And even if something hurt them, if it was looked good in their eyes, they would maintain it, right? And you'd have plenty of people who had what looked like good posture but had a lot of pain. And so I can recall situations. I remember I had a teenage girl at one point that her mom was mad at her for slouching, but she would say, when I slouched, I don't have pain. And so we had this whole conversation about, well, it's probably that's what you need to do. Like slouching for right now is okay. That we need to listen to your body and move
Yeah.
in ways that don't cause more pain. And if sitting up straight with a rigid posture hurts you, then that's probably not the right thing for you right now. And even just like you say, just keeping it simple from a functional standpoint of what are the things you want to return to, and how can we gradually start to bring that back? And almost think of that as part of your rehab, and just
Yeah.
make that kind of the program and just gradually expose you to it. It makes a lot of sense. It's simple and it makes sense.
Yeah. And
It's
actually CFT's been really good. Speaking of making sense, what they try to do in their pain education is the first step is making sense of pain.
mm,
They always say that, Pain has to
Yeah.
make sense. And that's where they use the simple messaging and a really thorough exam and helping people understand what's going on. But I think so many other systems do the exact same thing as well.
Got it. Yeah, just use slightly different language. The
Yeah.
other thing that resonates, my mom's a psychiatric nurse practitioner, and my dad was a social worker. So I grew up in a very psychosocial sort of household, and I, for a lot of years, had really bad social anxiety. It started at a time in life it was when I was in physio school, and I had just proposed to my wife. And so I was really stressed. I was stressed from the physio school kind of situation, the proposal and engagement, just all that. And I remember I was in a circle of friends talking, and I had my first social anxiety attack. And then from that moment on, for the next decade, I was very sensitive, and it mainly was triggered by eye contact. So if I was in a situation where I had to sit still and make eye contact, I'd have these social anxiety attacks. And I really am not a very anxious person otherwise, but
Yeah.
that situation would trigger it. And for the longest time, because of fear, I would avoid eye contact. So I'd wear sunglasses, I'd choose things where I was outside. And it it actually ended up being one of the best learning experiences in my life, especially in my career now and interacting with people who have had longer pain states that have been around for longer periods, because I think it's helped me realize that avoiding those triggers actually made it worse.
Yeah.
And when I slowly started confronting it, it's not gone, but it's 90% better. And I think maybe that's true for a lot of persistent pain states where it's not realistic to think that this will go away 100%, but maybe you can really knock it down significantly and learn to cope and manage better in your life. And I think there's a lot of mental health disorders that are similar to persistent pain problems.
Yeah, you even see that in the CFT literature,
Mm,
where that these great series of papers or a huge study, sorry, and the pain only went from 6 out of 10 to 4 out of 10, but people were incredibly satisfied with it. And I think it's a really important message for therapists to know, like, you're not a failure if people still have pain.
yeah.
And when you look at pain advocates who are patients, Gilletta Benton, Bronnie Lennox Thompson,
Yeah.
I think Virginia McIntyre online, they aren't pain free.
Hmm.
They're living well with pain,
Yeah.
and it's learning to cope and deal with that. And but that's a really hard message, especially in our profession, because you have warring views. If someone's going to say, "Well, hey, you shouldn't be living with pain. Come
Exactly.
see me. I'll fix you."
Hmm. Yeah. So many patients have that expectation that somebody
Yeah,
has a fix for me that's 100% fix.
it's hard. Even in the
Mm.
psychological literature, this is the PRT stuff. Alan Gordon, the pain
Uh,
reprocessing group. They take a very psychological approach to pain, of being all neuroplastic is what they call it. It's all brain driven, and you just have to change how the brain views the problem, and you'll be pain free, is what they say. And
hmm.
and their results, not unfortunately, results are very strong, like going from 4 out of 10 down to more than 50% of people said it was 0.
Hmm. Hmm.
And so it's like, as a
Yeah.
clinician, it's almost too good to be true. Like, if these
Yeah.
people, because they said that they were all chronic pain sufferers, and I'm like, oh, this is great, but is it? Like,
Hmm.
is this setting people up to fail because you've set this expectation? I don't know how reasonable it is.
Yeah.
Yeah, no,
Yeah.
it's a tough
I
one.
know you have a lot of focus on persistent pain. I know it's one of the things you talk about, and I know you're not, seeing a ton of patients right now, but is that an expectation you would set with people up front? Would you, because I was just talking to somebody on the podcast the other day, a podiatrist actually, and she was talking about how with some of the chronic foot presentations, sometimes you'll ask people, like, would you
Yeah,
be happy with a 50% reduction in your pain? And I think that was interesting to me to think about framing it that way for a patient up front, kind of setting the expectation of this might not go away completely, but what about if it went down in half
yeah.
or a quarter? Will you talk about that
Yeah,
with
I do.
patients?
I just
Mm.
did that the other day,
Hmm.
where I'd be like, so you might be 100% pain free, but for a lot of people, when you've had it for years, it's really not possible. But I've worked with people who they get it down, and there's an amount where they're just comfortable with it, where it's not freaking them out. They're not suffering anymore. Like, what are your thoughts on that? So a lot of people are really open to that.
Mm-hmm.
And I say, like, I say the irony of this is, like, when you give up on trying to fix something, sometimes
Mm-hmm.
you end up fixing it.
Yeah.
It's weird. And the best example I always give is like falling asleep. You don't go to bed
Totally.
at night and say, I need to try to fall asleep,
Mm-hmm.
right? You don't force yourself to sleep.
Yep.
Something happens and you fall asleep.
Yeah.
As soon as you worry about sleep, you stay awake.
Yeah.
And so I wonder, like, if there's a subset of people when we're always focused on fixing, it just messes things up. And so you shift the focus to like living well.
Mm-hmm.
I say that, and then I'm like sheepish as a therapist because I'm like, maybe like I've given up too soon. And if I was more confident, like in the other group, like the pain reprocess thing, maybe there'd be a 10% increase in the people where I could absolutely help them get to 0%. So it's tough. It's tough. It's hard to be a therapist. It's hard to be
No.
someone in pain.
Yeah. People are
Conflicting
complex.
messages. Yeah.
Yeah. It's I totally hear you on the sort of worrying about, like the sleep example is a great one when you worry about falling asleep. But my 10-year-old daughter does this sometimes. The older one doesn't, but she'll sometimes say like, "Hey, what?" She'll always say at night, "What if I can't fall asleep?" I'm like, "Sweetie, you will fall asleep. It's okay. You always fall asleep." Like, and so we have this little system now where I tell her I'll come back in about 10 minutes and I'll tap you on the head. She has a sleeping mask, so she can't see me, but I'll tap her on the head, and if she, so it reassures her. But maybe I'm creating dependency. I'm probably creating
Well,
dependency
yeah,
on
that
that.
might be a safety behavior you have to remove. This is tough.
Exactly.
Does she
But
have OCD at all?
she,
Any
I
other?
actually had quite a bit of that in high school, and probably to some degree still do it. It mostly helps me now, kind of
Okay.
stay consistent with all the things I do.
All right.
But I see tendencies in her and her older sister, with some of their behaviors. They'll do some behaviors that are sort of these repetitive. It's not like it limits them functionally, but I see some things where I'm like, oh, there might be a little bit of the OCD tendencies there. I wanted to ask you though,
Yeah.
on that idea of like not being able to fall asleep. I feel like so many patients, I feel like stress and kind of hypervigilance, worry is such a huge driver
Yeah.
in so many of the problems that people take away the really straightforward mechanical injuries and
Yeah.
things like that. But the people who have these kind of just pains that have been around for a while, I feel like so much of it is stress related. And maybe it's that they're overwhelmed in their life. I think there's Western culture kind of has this hustle and grind mentality.
Yeah.
And, you've got to be doing all these things. And, I think people, do you feel the same? Do you feel like you see something similar? And if you do, how do you coach people through that?
So I use the cup analogy for pain, which is like
Mhm.
you have pain when all these stressors and all these traits, they fill your cup, and at some point in time your cup can overflow and it's just too much and you have pain. My concern when we talk about the multidimensional nature of pain is that people feel like all of these things in their life need to be fixed. And then they're like, I'm screwed because I can't change my work stress.
Hmm.
So I'm like, you don't need to. That work stress is in the cup, but there's other things we can work on so the cup doesn't overflow. Because you know what I mean? If you set them up, be like,
E-
oh, you don't sleep well.
Exactly.
And they're like, I haven't slept well in 30 years.
Hmm.
And I've done cognitive behavioral therapy for it. I've done your stupid sleep hygiene, and you're just stressing them out even
Yeah,
more.
totally.
So to me, it's like, let's look at those things, acknowledge them. They're part of the puzzle. They help explain what's going on. You're not weird. This is normal.
Hmm.
Let's not work on those things.
Yeah.
Let's talk about the other things that you want to work on. So we build up your cup, so to speak.
Hmm.
That's my approach there. Because I
Yeah.
think like just like telling someone, oh, you have knee pain because you pronate, which probably won't change. Telling someone they have like low back pain for years because they don't sleep well could be just as demoralizing and harmful.
Yeah. Yeah.
Or
You're just adding more
depression,
stress. Yeah.
like, oh,
Yeah.
you have headaches because you have depression, and they're like, well, I'm screwed then. I've had depression for 20 years. It's not
Hmm.
really something we cure. It's something you manage,
Yeah.
right? So you gotta watch that.
So in your communication with them, you're basically you're obviously thinking about these different factors that could influence their pain, but in that conversation with them, if say they say something to you like that, I haven't slept well for 20 years and I've tried all these different things, then
Yeah.
you'll just, well, then we won't worry about that one. We're
Yeah,
not
you
going to
say
worry about
that
that
could be
one.
part of it, but let's work on other things.
Mm-hmm.
So I lay it out. that's what's nice with like people have often read my book before they see me, so they get an idea. So it's a bit easier for me.
Yeah.
These ideas aren't coming out of left field, but I'll say like, this is how pain works. What do you think? What else
Mm.
do you think we can work on? Right? And I had someone we were working. She was a runner. We were working together, and then she's like, you know what? I think I need to see a therapist for this, this, and this,
Hmm.
and
That's
it's not
amazing.
you,
Yeah.
essentially. And I'm like, good, good. Let's talk through email. Let me know how that's good. And I didn't feel like I was useless, but I
Yeah.
was like, okay, good. I think something that this could work for her. She needed to
And
see a
that's somebody,
CBT therapist on something.
wow. And
And I
she
was
had
like,
read your
great.
book prior to seeing you.
Yeah, and then we did some stuff and all of that. Yeah.
It makes
But,
you wonder that seems like a great model. It kind of reminds me of the Explain Pain because they were doing that for a while, right? Like where they'd have people read
mhm.
that book before. It was like part of their treatment model, I think, right?
Yeah, I don't do this. People will just read it and then get in
Just
touch
happened
with
to
me
have read it.
online or something. Like, I actually think I've been saying this for a while, and I shot a video, and then the quality was poor. I wouldn't mind doing like a YouTube series on like
Hmm.
things to expect when you go see a biopsychosocial therapist and
Hmm.
stuff like that. Like, here's the questions we might ask, and be like, why the hell is this guy asking me this for my back pain?
Yeah.
You know what I mean? Like a little primer for people. I think there's something there just to get them thinking, because it can be shocking, if you're asking all these weird questions about stress and sleep and your thoughts and beliefs and anxiety, and you're like, just came here to get my back cracked, dude.
It is kind of funny. It's kind of funny. I haven't thought about that way. I think where I live in California, people are so holistic in
Oh,
their
okay.
health that people almost seem to expect that health, if you're talking about health, I don't know though, I could be wrong. This is probably my bias, but I sort of assume people are more aware of like nutrition and everybody's listening to Huberman and
Yeah.
they just like they're thinking about all these things, but that is really interesting. I I mean, how cool though that particular patient, to have a conversation where you can be like, what do you think we should work on? Even a question like that.
Yeah.
Maybe it's laying it out for the person if they've never seen that information. Maybe it's laying out these are all the factors that can influence
Yeah.
your pain system. Which ones do you think
Yeah.
would make sense to work on in your situation?
Yeah. So like, that's why I use the cup. This is what I think
Yeah.
is in the cup. For homework, tell me if I'm wrong or what I'm missing. And then the next step is, what do you want to work on?
Mm-hmm.
And sometimes you may not be the right person, right?
Mm-hmm.
But this is what's great. A lot of our simple interventions work on a lot of things in the cup.
Yeah.
Right? What does a walking program work on? Is that just a mechanical intervention? No, absolutely not. Especially if you join a walking club and start
Sure.
hiking. You know what I mean? Like,
Exactly.
that's what I mean. Simple mechanical interventions aren't just mechanical. Like, I heard someone say, you can't just treat the knee. There's psychologists for knee pain. And I'm like, well, that's true, but not how you mean it.
Mm-hmm.
Which means like, even if you just do an exercise or walking program for the knee, you're not just treating the knee.
Yeah.
You're also treating their emotional views on their problem, their cognitions. You're treating their whole nervous system, you know, their pain perception,
Yep.
their family, their meaning, all this stuff. So yeah, you're right. You can't just treat the knee.
Yeah, exactly. Yeah, there was a cool, I don't know, I think it was actually talking about Huberman. There was kind of a cool thing I saw him talk about in the visual neuroscience world where they found that just thinking about all these factors, all these things that walking could influence, but it was this thing where it said if you walk in a safe space, like say you're out in your neighborhood going for a walk, this horizontal kind of gaze stabilization, your eyes kind of go back and forth, can actually calm down your amygdala. So it
Oh,
will kind of like ramp down activity in your amygdala. And I thought that's like, because I agree with you. I often go for walks and it's like, yeah, I'm not being sedentary. I'm getting some exercise. I'm out in nature. We're lucky to be somewhere that I can walk and there's trees around. Like oftentimes I'm walking with my wife. Like there's so many aspects of
mm-hmm.
that are good for my health. And to know which one is having the
Yeah,
biggest impact on my system is impossible.
yeah. Who cares?
Yeah,
Yeah,
exactly.
no.
Yeah. Keep it simple. Um, so okay, so we talked a little about persistent pain. Can you talk just a little bit? We talked about it briefly a second ago, but the kind of load and stress management, this has been really popular in physio, I think, over the last few years. What does that mean? Like if you're talking to a patient about load and stress management, how do you explain that?
Uh, so I can give you an example more like with a runner, so it's more concrete.
Yeah.
So we'd say, yeah, you get knee pain really when you just do too much for what you're ready for.
Hmm.
That's it. But then I would say, but what you want to think of, too much isn't just running. It's like, what are the other things new or different going on in your life? That's what we want to look at.
Hmm.
And then that's only one side of the equation. That's the stressors. And the stressor means all the stressors in your life.
Not just physical.
Yeah.
Yeah.
Yeah. And physical too, because a runner won't think of the other physical. Like they might start renovating their basement or something and they've
They've
been
been going
kneeling all
downstairs a
day.
lot or something.
Yeah,
And yeah.
all that
Yeah.
stuff adds up. Then you want to say like, hey, those are the stressors on you. Are you in the best state to handle those stressors? So sometimes you see this with a runner. This is just the other day. It was like, my training is the same. I've been running the same program. This is my 12-week marathon build. I've been doing it for 20 years. I know their coach. Their coach is excellent. There's no spikes in training. There's no training errors. And I'm like, you know what? That shit just happens because when you're pushing yourself, you're right at your threshold of what you can adapt to. And who knows, maybe something in your life which is a little bit different. And for some reason, you couldn't tolerate that stress that day, and then boom, you just fell into the pain cycle, and then it just happens sometimes. So like we want to say, are you in the best state to adapt to these stressors?
Hmm.
And again, it's often the psychosocial stuff. So like with the runner,
Yeah.
we would say, what you're eating like. Are you regularly getting your periods, or are you perimenopausal? So things have changed, right? Like,
Yeah.
so it's still physiology.
Hmm.
Even though we talk about psychology and social stuff, it's still physiology. So
Sure.
so that, does that help at all? Is that
Yeah.
interesting?
No,
Yeah,
for
that's the
sure.
idea with the load management. It's like
Yeah. Yeah.
loads and who you are to adapt to those loads.
Yeah. No, that's cool because I thought you were going to only talk about load from a tissue standpoint, managing loads on tissues, but to hear the integration of psychosocial stressors is again like
The,
this is why I like your perspective, and I think it makes sense. Again, especially I'm biased a bit because I came from such a psychosocial household, and I
yeah.
think it has been really helpful in my kind of physio journey. But I think those types of stressors really do they pile on, and it
Yeah.
influences. It's all physiology, like you said. So it's
So even load, like the problem, this is why I'm critical of biomechanics, is like we can quantify a lot of these loads, but we don't know which one is it the rate of loading? Is it cumulative loading? Is it the peak load per step? We don't know which loads are the most important.
yeah,
Neo A, like you can lose weight. I love this stuff. I've said this 1,000 times, but you can lose weight. People are like, oh, great, less loads on the knee. In some people, and some people, they lose weight, the loads on the knee increase
hmm.
because they walk more and they take a longer step,
Yeah, I got
and
it.
they do just as well.
Hmm.
So like we're so worried about load, and maybe we shouldn't be. We're not there yet. Or like femoral neck stress fractures are a scary thing in runners. The last paper, not the last paper, a paper I've read, this is an older one. There's like 37 of them, I think. They're in the 30s, stress fractures.
Uh-huh.
But like 16 of them, there was no change in the loading. Same programming for
Hmm.
months. They
Hmm.
couldn't figure out why they got the stress fracture.
Hmm.
So the load management would have done shit for that.
Yeah.
They just happened.
Hmm.
So there's some things we're not able to measure yet.
Yeah, totally. The conversation with a patient like that runner you're talking about whose program had been the same forever, and you start thinking about other kind of stressors, is that I feel like sometimes people will get bummed about that. Like, and maybe this is a person who knew you and had some expectation that direction, but where they're like, there's not a simple mechanical fix.
Well, so this is what's great. There can, just because you can't figure out the cause. My example is like the domino idea. They have a room full of dominoes. You knock
Mm,
down the first one. That was the cause of them all going down. Okay.
yeah,
Now that they're going down 20 feet from the initial one, to stop more getting knocked over, you don't go back and pick up the first domino. right? That's irrelevant what happened in the
Mm-hmm.
past. You got to
Mm-hmm.
go stop it where they're falling down. You
Yeah.
got to stop that cascade. So it's the same thing with pain. Like,
Mm.
so I'm like, don't worry about why you got into it. What
Got it.
matters is why it's being perpetuated, right? So sometimes it is still a simple mechanical fix.
Because that's where they're at right now.
Yeah, we don't need to know. We don't have to be Columbo. No, that's an old reference. I was older than me, but anyways, I would have seen like the references years ago. You don't have to be Matlock. I don't know.
Yeah.
Judge Judy. You don't have to figure out why to
Yeah.
help with what's going on.
Mm-hmm.
So
Mm-hmm.
yeah, it's great.
That's a good way of thinking about it. Yeah, because that is the tendency, probably for a lot of practitioners and for the patient, of course, trying to figure out what was the root cause. Everyone, like, what's the
Yep.
root cause that started this whole thing? But let's just
Shit
focus
happens.
on where you're at right now and not worry about that. Let's address what's going on right now.
Why do people get anxiety or depression? This, you're not going to find the root cause there.
Sure.
It's too complex.
Yeah. It's amazing how much of what we do has similarities to,
Yeah.
kind of mental health type therapy, psychology, and
Oh, just even going across fear or concussion management.
mm,
Calm it down, build it up.
mm-hmm.
Fear, calm it down, exposure, build it up. Right? We
Yeah.
do all the same thing. My one daughter has pretty bad OCD with intrusive thoughts.
Mm.
And a lot of it is not going and tapping on her head and making sure she's okay.
Yeah.
We're not allowed. That's not the treatment. It's not telling her she's okay.
Yeah.
She always has these worries. They're often around health or things, and her thoughts just come in her head. And we don't tell her to reason with it. We just say, "Buddy, that's the OCD. Those thoughts are coming in,
Yeah.
whatever," and we just blame it on the disease. We don't try to rationalize or anything like that.
Mm-hmm.
And then that's it. She's made sense of it, and she gets comfortable with the thoughts. Is the idea? Yeah.
Yeah, totally. Yeah, I need to probably. It's
Well, maybe you should.
No,
see
I know. Well, luckily, it's not like a super.
Yeah. It's not in the way. No.
It's not in the way, and it doesn't happen every night. But I probably need to rethink some of that stuff. You know what's funny? Psychology. I have a friend who's a child psychologist, and there's so many times where you think you're doing the right thing. Like with kids, this happens more than anything, I think, and you think you're helping them cope with something the right way, and it's so funny how often I kind of detach my physical therapist brain from my parent brain.
Yeah.
And I think I'm doing the right thing. And then I'll talk to my child psychologist friend. She's like, no, you want to actually do this. And when they explain it, you're like, that makes so much sense. Why did I not think to do that?
Yeah.
And it didn't even occur to me until talking to you just now, as I'm saying it, that doing that, the tapping on the head thing, is not allowing her to just deal with the issue on her own. It is a kind of a safety behavior, something that it didn't occur to me until talking about it that maybe that's not the best strategy.
Maybe, but it may not be so you can have safety behaviors that aren't unhelpful.
Sure.
That's the thing. It's not an issue yet. It's not getting in the way.
Yeah.
That's how I view those things. It's okay. Like sometimes it's like, yeah, I like. There's such a big thing in therapy now, like physio, to be patient centered and let patients guide and make choices. But sometimes you can tell people just want to be told what to do.
Sure.
And that's not always harmful, and that's all they need. They don't. It's like when I run, I used to have coaches. I know how to create a running program. I've even coached runners, but I just wanted someone to tell me what to do.
Sure.
Did I lose all my self-efficacy? No, I wanted that break.
Exactly.
You know what I mean? It's okay to be that. And so that's what I think with your analogy with your daughter. It's like,
yeah.
Not really, Aaron. It's cool.
Yeah, totally. Yeah. When you think about, there's so many topics I could ask you about, and I want to be cognizant of time, but when you think about kind of where rehab is at these days, and where the research is at.
Don't get me started.
The lack of research. What's my question here? Are there areas is there maybe an area or areas you could think of that are the most frustrating to you in terms of where you wish practitioners would change or our profession would change?
This is my big thing the past couple of years. I don't know if it directly answers it. Although I read a lot of research and I enjoy reading research, is what I've always done. I think it's overrated for the average person. I think you should just find your fundamentals
Hmm.
and then you fine tune them, and that's it. I honestly think sometimes we adopt research way too quickly
Yeah.
and it just becomes dogma. The glutes not firing, transverse abdominis stuff like that. So Paul Hodges did that work in 1996, abstracts in 95,
Yeah.
first paper in 96. And then I swear to goodness, like in 1997, it was in every physio curriculum
Yeah.
based on a cross-sectional paper that people who had pain when they raised their arm up only in one direction, the transverse abdominis would be delayed 60 milliseconds, and
Hmm.
somehow that meant the spine was unstable. And
Yeah.
then everyone's doing it. And we're like that didn't take 17 years to get into practice.
No.
It
And stayed in
should
practice
have.
for a long time. I mean,
It
it's still
should
in
have
practice.
taken 17 years. It
Yeah.
should have been vetted and validated and tested. And instead, like, I don't think it was his fault that they've had like a great marketing campaign
Mm.
somehow where everyone was doing it. And there was like, this is the way you treat low back pain. It was like,
Hmm.
what the hell? Like, so that's sort of been like my take now, especially with social media. Like a few research papers, people get excited, boom, suddenly everyone's doing isometric contractions for tendinopathy. And
Yeah.
if you weren't, you're a shitty therapist.
Hmm.
And like that stuff shouldn't have happened so quickly. And
Yeah.
then we have to right the ship with new research, and we just go down these. I don't know. So I know maybe that's not what wasn't what you're expecting, but that's been my big thing with research lately.
No, I think that's great actually. I for a while I was at Texas Tech. Phil Sizer was my advisor. You know, Phil Sizer was Chad Cook's advisor, and I remember Phil would always talk about the pendulum swinging in this profession.
Yeah,
And the social media thing you just brought up is really interesting because you would always hear those stats on how long it took for something to go from research to clinical
yeah,
practice. And I feel like that really has sped up so much, but maybe it can be a bad thing where it speeds up
hmm
so much that we adopt things so quickly before they've actually been validated.
yeah, yeah. And there's like a pressure to stay up to date and educate and change, and like maybe don't change.
Hmm.
Maybe double down on what you do, and what I would always recommend for those reading and a reflective practice is to take the things that you love and go challenge them. Mm, Understand why you have the opinions that you have, and
Hmm.
see if there's any fine tuning you need to do there. Right, instead
Yeah.
of adding something new, like go and go, stress yourself.
Hmm. Yeah. Yeah, this is helpful for me to hear because I think when you practice for a long enough time, you kind of develop patterns and you figure out what people are, every person's unique, and I think so much of rehab and physical therapy is uh, getting better at talking with people, like just building
Yeah,
rapport and relationships with people, and that really drives a lot of, I think, just outcomes we get with people. And for me, I'm posting daily on Instagram, and oftentimes something new will come up in the research, and somebody will leave a comment that is critical of what I'm posting, and I really try to not post things that are harmful in their language,
yeah,
or sometimes it's just an interesting thing. I posted a shoulder manipulation under anesthesia yesterday, and
I saw that. Yeah,
it pissed a lot of people off, and I wasn't like I was trying to. Sometimes I just find interesting things, and
yeah,
sometimes I get things wrong too. It's like I'm posting every day for 7 years. I'm going to have some errors in there. Um, but I think I mostly try to stick to fundamentals. And I feel like a lot of this I learned from you and the way you taught. And I think a lot of it is just from years of seeing people, and sort of part of evidence-based practice is your clinical experience.
yeah,
And while it maybe isn't, I mean, there's other aspects, the research and what the patient values. I do think there's a place for those fundamentals and what's worked over time and what you've seen with patients. And I think a lot of my rehab type posts and education kind of revolve around that. I'm not every day before I'm posting one of those, going and doing a literature review.
Of course.
I'm just posting things that I have seen that kind of tend to help people.
Yeah.
And I'm not, who knows what the exact mechanism is? It could be different mechanisms for different people.
Yeah.
So it's actually, your perspective is always refreshing to hear. But I do, because you feel like, oh, I need to be in the research. I need to be in the research all the time. And you'll start to sometimes feel a little down on yourself that you're not in the
Uh,
research enough.
no, no, I don't think so. I think you find the common thread or common denominators of good care, and then
Yeah.
challenge it a bit, and then get better at what you do.
Hmm. Well, man, thank you so much. Thank you so much for taking the time today. There's so many things I could continue to ask you about.
Part two.
What if people want to come find you, where would they go? I know you mentioned your book. Where can they get resources like that?
Yeah, that's just that's my website, greglehman.ca. That's
Yeah,
where the
people
book
can go get
is.
the book on there.
Yeah,
Yeah.
my clinic website, which I never give out. I'm not seeing a lot of people, but I do see people online and
Yeah.
in Toronto and stuff like that. It's weird. We just moved, so my clinic used to be a gym in my house, and now we're in like a tiny house in Toronto. It's our mud room. That's my clinic.
Nice.
Is literally there's weights,
Yeah.
and kids boots. Uh, is movementoptimism.com.
Okay.
That's the other area where people could see me, and
Yeah.
then Twitter and Instagram is Greg Lehman.
Okay.
Yeah,
Yeah, I'm not on Twitter, so I never get to see you over there, but I'm sure, are you, I would imagine you're probably pretty active.
not that active
Oh, okay.
anymore. There's less. It's just the same people saying the same thing.
Yeah. Yeah. Well, thanks, man. I appreciate it. I really do appreciate all of the everything you've done for the profession over all these years. I mean, how you've influenced my career. I mean, it was probably back in 2009, or I got out of PT school in 2007. It was probably 2009, 2010 that I started having some conversations with kind of that whole
That
pain
group.
science-y kind of
Yeah.
group on Facebook, and it really did it helped me so much in how I
Oh, good.
developed and kind of becoming more well-rounded, I think, in terms of just thinking about all the variables and factors that can influence someone's health and pain. And so, yeah, just thank you. Grateful for that
Oh,
work you've done.
of course. You're welcome. Thank you.
All right, man. Well, have a good day, and I'll see you next time.
Okay. Thanks,
Bye.
everybody.